Hey guys, this is Dr. Steve with GEM. This is a recording of temporomandibular joint assessment and treatment. So we're going to go through the observation, assessment, and different treatments for temporomandibular joint. So this is the first thing that we're going to do. The first thing we would do for someone who's experiencing jaw pain is we want to know where's the jaw pain and what symptoms are they experiencing. So let's say that our patient has jaw pain on this side. So we want to know the quality of the pain, the quantity of the pain, where all does it radiate. We're also very interested to know if she has like neck pain or upper back pain as well. So once we know kind of where the symptoms are, we want to ask about, is there any clicking or popping or perhaps locking of the jaw? So sometimes a patient will have where they cannot open the jaw all the way and there's a painful block and they can't get past that block. That means that the disc is probably anteriorly subluxed and they're not able to rotate the jaw and then slide the jaw forward on the affected side. So if we had a block on the right side, what we would see is they can open the jaw only so far, and then the left side will actually translate forwards and the right side will stay stuck where it is. And so we'll see a deviation of the jaw towards the affected side. That's if the disc is anteriorly displaced. If the disc is anteriorly displaced or medially displaced, but reduces, there will be a pop. So as she opens her mouth, it gets a little bit hard, and then there'll be a pop, and then that's when the disc relocates and she's able to open her jaw. Sometimes as the jaw closes, there's another click or pop, and that's associated with the disc subluxing again. So once again, if there's a pop upon opening, that's the disc relocating into the place where it should be so that the jaw can translate forwards. If there is another pop when the jaw is closing, that's the disc subluxing out of place again, usually anteriorly or medially. So the next thing we're going to check now is the range of motion of the jaw. So I'm going to bring the camera a little bit closer, and then I'm going to have the patient open their mouth. Can you open your mouth for me? So the patient's going to open their mouth, and I like to use a clear ruler just to measure how far they can open. Okay. So normal would be about 45 to 55 millimeters or 4.5 to 5.5 centimeters. If someone has an anteriorly displaced disc without reduction, we're probably going to see a big reduction in the opening of the mouth. The next thing I want to see is jaw deviation. So I'm going to have you open your mouth, and then you're going to deviate your jaw that way. Good, and we would measure that. That normal is about a centimeter, and then let's go the other way. And again, normal is about a centimeter. Okay, now I want you to jut your jaw forward. Jut your jaw forward as much as you can, like that. Good, and we can eyeball it. We're at about 0.3, 0.4 millimeters. If she could not jut her jaw forward, that means that the disc is probably anteriorly displaced and not reducing. Or if she juts her jaw forward and it deviates towards one side, that's going to be the hypomobile side, probably where the disc is anteriorly displaced. So that's going to be it for the range of motion of the jaw. So we did full opening, should be about 45 to 55 millimeters. We did lateral deviation left and right, should be about a centimeter to a centimeter and a half. And then protrusion, which should be anywhere from 0.5 to 1 centimeter. Okay. After we've gotten the measurements of the jaw, we want to check a couple of other things because usually there is some neck involvement with temporomandibular joint issues. So we would check cervical range of motion. So I'm going to have you turn your head to the left. Turn your head to the left as far as you can comfortably. Tell me if there's any pain, pulling, or discomfort. We use our goniometer to get a measure on that. Turn your head to the right. Tell me if there's any pain, pulling, or discomfort. Okay. If there is a gross loss in range of motion towards one or both sides, they may have upper cervical dysfunction. See, 1, 2, and 3 give you about 35 to 45 degrees of motion, about half of your degree of motion in rotation. So if she turned her head all the way this way, but she only got about half going this way, I would expect an upper cervical dysfunction. So we look for any pain or discomfort that may be there in the neck. Okay, the next thing we want to look at is how is our patient sitting how is their head sitting in relation to their body? Sometimes we see patients where the head is sitting at a bit of a tilt, a bit of an angle, either this way or this way. And usually that's indicative of an occipito-atlantal dysfunction, the OA joint, where the skull meets the cervical spine. So once again, if we see the chin deviated one way or the other, we may have a upper cervical dysfunction, especially at the occipito-atlantal joint. So that's of great interest to us. Something else that we want to see is the cervicothoracic junction. So as we're observing, we want to just kind of have a look at the patient's posture. Do they have a forward head? Do they have a normal curve in the neck? Is the curve a little bit more pronounced? What does their cervicothoracic junction look like? Do they have a mini Dowger's hump, a little bump here? Okay, so we've watched the neck move. Will you turn your head this way? Okay, so as we observe the neck movements, we want to see a good rotation and stuff like that. Anytime you see a deviation in movement, like a patient rotates their head and ends up here, or patient rotates their head and ends up here, anytime you see a deviation in movement, we have to evaluate that further and see what's going on in the neck, or neurologically, why does the patient prefer to move that way? Most of the time it's a compensation to avoid pain, or because of hypomobility and a facet in the cervical spine. That's for the neck. Now, we want to see the CT junction and the thoracic spine, how well they can move. And so to check CT junction, which is C6 down through T3, what I'm going to do is I'm going to place my fingers on C7, T1, 2, and 3. I'm going to have you rotate your neck. So turn your neck to the left. Okay. C7, T1, T2, and T3 should all move a little bit when the neck is rotated. C7 and T1 move, T2 and T3 are not moving. So that tells me that there's some hypomobility in the CT junction, which is placing extra strain on the neck. She has to compensate elsewhere in the neck. If we're treating a jaw, we need to treat the neck. If we're treating the neck, we need to treat CT junction and probably at least thoracic spine in the first 2 ribs, okay? How do we check? So that was CT junction. C6 through T3, we check for the rotation in those. They should be moving. We can check for rotation. We can check for extension. Raise your arms up overhead. This gives us extension at the CT junction. It also gives us extension in the thoracic spine. Can you scoot forward just a little bit? Like put your bottom forward in the chair about halfway. That's perfect. Okay. So let's take a look at her thoracic spine. So there's the thoracic spine. It's got a pretty good shape. It's not too rounded or anything like that. Lift your arms up in the air. Lift your arms up, arms up, arms up. And as she lifts up, she gets great extension in lower thoracic, mid thoracic, and at the CT junction. So those are moving fairly well. Arms back down. Any hypomobility we find or lack of extension that we find is going to be an issue causing thoracic kyphosis, forward head, and now the muscles that control the jaw, a lot of them are sitting biomechanically, mechanically different, and that can cause deviations in the jaw movement. Scooch back a little bit. Okay, so let's come and check now first ribs, so ribs 1 and 2. Here's how I like to check them. I'm gonna bring you right here. So the first rib is kind of like a choker necklace. It sits at the base of the neck, right if you follow the neck down to the base, right there is going to be where first and second ribs sit. So first rib, let's go in like this. I'm going to push down towards the opposite hip using the MCP of your second finger. So there's first rib, this side, that side. And I want to know if any of those are, if one of those ribs is elevated or if it's tender. So I'm going to check this one, check this one, check that one. They seem to be all right, but if one of them is noticeably elevated and tender, then that rib may be sitting in dysfunction. If you have a upper cervical dysfunction in C1, 2, and 3, you will definitely have scalene hypertonicity on the affected side, which can cause first and or second rib to be elevated. So if we've got an upper cervical dysfunction or hypomobility, you will have a rib dysfunction. That's just how the body works. So first rib. For second rib, we're going to come posteriorly and we're going to take a look at the suprascapular space. So here's the spine of the scapula. Okay, let me see. here's the spine of the scapula. So here's the suprascapular space where supraspinatus sits. We're gonna come just in front of that, and there's second rib, there and there. All right, there and there. And so we wanna check and see if there's symmetry, if one side is higher than the other. The right side is higher. And then we can check for mobility. The rib should spring. The left side springs well. The right side does not spring well, so she does have a second rib dysfunction on this side because of scalene hypertonicity, and there's maybe something going on in the neck, okay? So that's it for our joint mobility, except for the jaw. So let's take a look at the jaw. Just before we do though, I wanna make a special mention that CT junction and thoracic spine are important. If they're very rounded, the head's gonna come forward, and that's gonna cause issues in the muscles that control the jaw and in the upper cervical, and that can cause a lot of issues, pain in the head, neck, face, TMJ dysfunction, okay? But also too, there is a thing called T4 syndrome. So the T4 is of great interest to us. If T4 is in dysfunction, it can cause a host of symptoms in the head, neck, face, dizziness, headaches, migraines, sometimes ringing in the ears, TMJ issues and stuff like that. So really the whole thoracic spine, CT junction, first and second ribs at least, and cervical spine are all super important. Something we can check as far as the muscles go is deep neck extensors versus deep neck flexors. So what I'm gonna do, and I'm gonna show this to my patient, is I'm gonna say, hold your head here, don't let me push it forward. Hold your head here, don't let me push it forward. And that's rock solid, that's nice and strong. Now what I wanna see is the cervical flexors, the deep neck flexors, which are typically weak. I'm gonna push the head back, and I'm also gonna try to push it into extension. So I want you to hold your head here, don't let me move it, okay? And you can see that she, like most patients, will lose the flexion part of it, showing that there's an imbalance between the deep neck extensors, which are very strong, and the deep neck flexors. There's also a deep neck flexor endurance test. We teach that in our cervical practice patterns. We will not be showing it today, but there's another test for that that's established by the research. This is just kind of a quick and dirty test. Okay, so now we're gonna check for jaw mobility or TMJ mobility.